Thank you, everyone, for being here for this important conversation where accessibility intersects with the health field. Thank you to blackdoctor.org and USA Today for bringing this critical conversation. My name is Andrea Jennings. I'm an accessibility strategist and host for Access for All, Integrating Accessibility. Our panel highlights the intersection of healthcare access, disability, and race. According to the Centers for Disease Control and Prevention, CDC, 1 in 4 adults in the US has a disability, highlighting the widespread impact of accessibility barriers. Disability impacts people of all races, genders, and socioeconomic backgrounds. Health inequities persist, particularly at the intersection of race, disability, and socioeconomic status. And today we're here to discuss real solutions. The conversation brings together leaders in pharma, technology, policy, and community advocacy to explore how we can create a more equitable health system. I'm excited about this conversation. We'll focus on systemic barriers and how the role of storytelling, technology, and community-driven solutions can move us forward to empowering patients with access to healthcare. I'm also excited to share that today's panel and conversation is being televised as part of a new pop culture television series, Access for All, Integrating Accessibility, produced by Pasadena Media. And at this time, I want to thank Pasadena Media. So let's meet our esteemed panelists who are driving change at the intersection of healthcare policy, storytelling, and technology. Donna, let's get into this right now. Donna, can you introduce yourself? And after, I would like to know, we know that lupus disproportionately affects women of color and is often underdiagnosed. But given your expertise, what are some concrete ways healthcare providers and policymakers can address disparities like the underdiagnosis of lupus in Black women?
Well, so to start, I'm Donna Finale. I lead sustainability in the US for a company called UCB. We are headquartered in the US, in Smyrna, Georgia, right outside of Atlanta. And our global headquarters is in Brussels, Belgium. In my work, I work across sustainability. I have a huge focus, on equitable access. And that is what we're going to talk about today, and specifically a little bit about some of the areas where we concentrate our work on at UCB, which is immunology. So we have rheumatology, dermatology, neurology, and rare diseases. So we asked about lupus. So it is rare that you'd be in a room like this and not have multiple people that say they have loved somebody that's either lived or lost their life from lupus. It's not only often misdiagnosed or not diagnosed. Unfortunately, it is a leading cause of death of young Black women today. And what's heartbreaking yet opportunistic is there is a lot of change that can happen that would be meaningful to health outcomes for people living with lupus. So we mentioned changes for healthcare providers. So I feel like being later in the day, a lot of things have already been said, but what do they say? You need to say it more than once. So healthcare providers, getting access to, somebody just mentioned primary care is challenging. Access to specialty care can be impossible, depending on not only lupus is an area that predominantly impacts women, women of color, but let's talk about intersectionality. Women of color on Medicaid or on different types of insurance that are more challenging. Oftentimes, even in areas such as New York, where we are, with all of the healthcare institutions, the average wait time can be 8 to 12 months to see a rheumatologist. So what can our doctors do? Do things to prioritize the sickest patients. Let's keep them from being seen in ERs where they would be not given the ideal treatments. They'd be given things like steroids that may hurt them, could possibly hurt them more than the disease itself. So, and then other things, inclusivity in clinical trials, offer clinical trials. I think this has been said already, but more often than not, we being representing a pharmaceutical, a biopharma, we want trial enrollment to increase. We want diversity in our clinical trials, yet we constantly hear, I've never been offered a clinical trial. So I think it's really about helping create access. And part of that is starting at the beginning with research. We also mentioned resources and not knowing what resources. For our physicians, partner with your advocacy groups, partner with your hospital administration, know what you have to offer. We often hear, especially in lupus, that social determinants drastically impact or impede a person's ability to get care. We've done research looking at all the things that would help, and oftentimes most of them are actually available, but people don't know or they're not offered. We then mentioned policymakers. What can policymakers do? So we're speaking about disabilities. So for instance, in lupus, recently had a conversation. We have tremendous lupus organizations, advocacy, LFA, LRA, LADA, these groups that dedicate their time to helping on policies. We talk about things like disability designation. So those type of groups really help people living with lupus navigate all the administrative burden associated. However, to date, it used to be 18 months. It's now 24 months is the wait time in many states to be designated disabled, which I don't know if we realize what happens in the meantime, but no coverage. No coverage for care, no coverage for medications or services. So it's really problematic. One of the groups I'm referring to talked about helping hundreds of patients in the last couple of years fill out the administrative work for disability designation. And they said only one in a couple of years out of hundreds received approval on the first try, and that patient was in a coma. So a lot to be said for that. Yeah. So just changes in things like those type of policies, looking at better reimbursement, better depth of coverage for community health workers. We had our wonderful dermatologist speaking about HS. We have an HS coalition there that they're fighting policy or working with policymakers to change state policies for coverage for medications. So just a lot to be done by both healthcare providers and policymakers in lupus.
I love that. And one thing that you said that was really important was prioritizing those that need that care the most. And continuing with that thought, what roles do companies like UCB play in advancing health equity? So
really it's about how we prioritize our efforts. So as I mentioned, sustainability is an area that goes, depending on what industry you're in or which person is leading it, can focus on different areas. But the one common factor around sustainability is that in healthcare, we all really do want people to do well. Some want it for different reasons, but ultimately, as a biopharma, we want our medications and our services and our treatments to work. We want people to do well. So we really prioritize the work that we're doing with the communities. It's really important. We put a lot of effort into understanding root causes of disparities, making sure that we take very methodical approaches to determining and not being wasteful. So the resources are not exactly plentiful in this space, as many of you know. So we try to use them wisely. And the idea is just, how do we be a good corporate citizen? And part of that is just making sure, most important thing we could do is have a robust pipeline of great medicines. Second most important thing is make sure that people who need them can get them, regardless of who they are, where they are, or how much money they make or what they look like.
Not so much. Thank you. And Herb, Dr. Caldwell, I would love to get your thoughts on dementia and Alzheimer's disease. And please introduce yourself as well. And then answer, please, for us, as a growing public health issue, what do we need to know more about Alzheimer's disease and dementia?
Sure. So good afternoon. First of all, thank you for having me. These are important discussions, and I'm thrilled to be a part of it. I'm Herb Caldwell. I'm from the St. Louis area. Spent a great deal of my career in the higher ed space, various facets. And what I've really appreciated most about being in that space is the ability to help young persons navigate from one level to the next. And education has been a great tool and enabled them to do so. And I get to continue that as lead for the Mama Joe Project, which is an initiative to reduce disparities around health and caregiving for elders with Alzheimer's and dementia. I'm personally impacted, and core to our efforts is a documentary film that we've just released. It's on the PBS platforms called My Mama Joe, Hope and Help. It is my family story, right? And so just showing not only what that experience looks like, but talking about some broader themes. So within the film, we've been able to include educators, scholars, practitioners from all across the country to give us some best tips and guidance. And so for us, it's about it being an educational tool, so families will have more information than my family had when we started. And so if you asked me, what do we need to know about Alzheimer's and dementia? First of all, we need to know about it. It's one of those things that even, and I'm talking just 2 years ago, I couldn't distinguish for you that dementia was not a disease, but a set of conditions. There could be 70 or more types of dementia. Alzheimer's is a very specific one, a disease, a brain disease, which my mother had, right? And so there was just, again, so much information we didn't have. It's something that can impact us regardless of your background, your layer of identity. But we also know that certain communities are disparately impacted. Age is a leading risk factor. If you're a woman, Black, Latino. So my mother, being a 60-year-plus Black woman, was the triple threat of risk. But these are things we don't hear very much about. So how about, you mentioned storytelling, how about we do storytelling from that perspective? And so that's what we're doing. We're telling the story, but using this so that other families across the nation can really be helped and they can really understand. If we're talking about disability, if we're talking about access, and this is a word I'm probably going to continually use, it's about being connected. Connected to resources, connected to support.
Thank you so much. And you're right. We just need to begin those conversations, right? Following up on that, you touched on storytelling as related to reducing disparities around dementia. Explain how you've incorporated film and arts into strategies that are community-based and accessible.
Sure. So if you're talking about a chronic illness within underserved communities, it can be tough. You're already dealing with so much trauma, so much pain. So what strategies are you using to be creative in that? And so we've taken film, we've taken media, we've taken music, we've combined that with education, scholarship, research, along with community engagement. So what we do is we have what's called community engagement forums, and we're partnering with churches. We're partnering with colleges and universities, community organizations, and we have this 2-hour event, most often in a movie theater or auditorium. And we show the movie, which is right about an hour. And then we have 3 or 4 local experts, someone in brain health, someone in dementia navigation, someone who can talk about how to use your Medicare and Medicaid benefits, someone to talk about how to set up a will versus a trust. And so within these 2-hour event, you see the film, you hear the discussions that's happening, you have a chance to engage. And don't underestimate the power of being in a room with other folks who may share your background, who may share your identity, but they will share your pain when it comes to caregiving and doing so without appropriate resources. So one of the worst things that can happen for the person experiencing dementia, as well as the family caregiver, is to have to do so in isolation. And so one of the core things for us is, how do we reduce stigma around this? We don't want you caregiving in silence. We don't want you navigating Alzheimer's disease in shame. And so using our family's personal story and film has kind of helped to destigmatize, all of that. So they see the film, then I'm holding this because this is one of the key things that we do. Because you've seen the film, you've heard the conversation, but we want you to walk away with something. When you're dealing with Alzheimer's or any type of chronic illness, you just don't have the time, energy, or brain power to go through 4,000 different websites. But what if you have a 40-page or less quick reference guide that a fifth grader can understand, that gives you definitions, right? That gives you caregiving budgets, that tells you what the early signs of dementia are, right? So something you can be useful and reference. And then we most often are working with local organizations who can also provide our folks information. And I got to tell you, we give feedback and evidence and evaluations. And so we know that as a result of having attended these, and we've done 11 now in 4 different states, people are connecting with their primary care physicians. They're going and getting testing. They're connecting with caregiving support. And that's what it's all about for us. Again, access, connection.
I love what you said about plain language. That's very important. That is something that's accessible. And so since we're talking about stigma, we're going to go to Michael. Michael, please introduce yourself. We talked about stigma in AI, and you're going to teach us how we can destigmatize that as well. And Michael, before you answer your question, or after you introduce yourself, tell us how AI and digital accessibility are transforming healthcare. Tell us about patient education and how AI can be impactful. Let's discuss some of those key developments. What are some of the biggest opportunities and risks in AI-driven healthcare?
Just all the softball questions. I'm Michael Bervell. I'm the current CEO and co-founder of TestParty. We're a venture-backed startup focused on digital accessibility. So you've heard a lot today about lupus, about Alzheimer's and dementia. These we would call the physical manifestations. If you think about this in the physical world, how does that apply to the internet? I'm a Zillennial, Gen Z, millennial. So for me, the internet was a daily occurrence. I remember one of my first memories of computers and technology was my Xbox 360, and I bought the Kinect, which was this way that you could control the Xbox with your body. And for me, when I used the Kinect at nighttime, it didn't work. It wasn't designed for people with darker skin tones. And that was the beginning of my transition, my world into accessibility within technology. I went to Harvard, studied philosophy, was a consultant for Google and the United Nations on accessibility strategy, and realized that most of these companies hadn't figured out how to make things accessible. In the physical world for sure, but definitely not within the internet. So what our company focuses on now today is automating digital accessibility. We have technology that can look at the source code of a website and within one click suggest fixes to global standards, both in America, Europe, Canada, and beyond. So that's really the focus of what I think about. And when we think about healthcare institutions, especially in a post-COVID world, almost everyone is using the internet to schedule appointments, to get medication, to get reminded about anything that they have to do as it relates to their healthcare and their health. So there's this question of, if a website is not accessible, who's not able to get health treatments? Who's not able to schedule appointments? And more and more and more. Then you think about intersectionalities. If you're Black and in healthcare, if you're in a hospital system that doesn't have extra capacity or budget to pay for consultants for $500,000 to audit your website and fix your website and then do that every year, sometimes people just don't think of these as core factors of a business's operations. And for us, it very much is. So we've been working over the last couple of years with a lot of private businesses, Fortune 1000s, health institutions, insurance companies, to ensure that everything is accessible. So I'll highlight 3 things that we've seen as problems within these conversations that you can share with your constituents. One is the bias that's available in the data today. We use things like ChatGPT, and it's built and based off the internet. In our business, we know that 97% of the internet is not accessible. So if you ask ChatGPT a question about how do I make my website accessible, it'll give you the wrong answer. The same is true with health data for Black and brown folks. If you went and said, am I diagnosed with XYZ? If there's not enough training data in the data set to have answers, you're not going to get the right answers. This is a core thing that we've been seeing. A second major issue that we've been seeing, at least within the health space, is just access to dollars. Do you have dollars and access for funding, specifically for Black and brown populations? When the president paused some of the funding for DEIA, we were directly affected. We had received almost $300,000 from National Science Foundation to do the work that we were doing. And there was a time that funding was completely paused. And so we started this business thinking accessibility is almost the most unifying factor. Why not build more access when people with disabilities have $17 trillion in spending power, and it has become politicized? So this is something that a lot of institutions are struggling with and are facing. And I would say, the third issue is something that's really popular in the disability community, and it's a really great saying, which is nothing about us without us. If you look around your boardrooms, how many people on the board have a disability? If you look around your employees, how many have a disability? And if you're a healthcare provider where you're providing for people with disabilities, sometimes the best way to break that bias, not just in algorithms, but in our own personalities, is to actually interact with people who have disabilities and to learn their stories. That's been one of the biggest things I've learned from being the CEO here at TestParty, is just what it means to build an accessible world every single day and every moment, not just when it's convenient.
I love that you brought up nothing without us, nothing for us, but without us. I'm messing it up now. But it's important that we hire disabled individuals. We don't just tell their stories for them. So thank you for bringing that up. How do we ensure that these tools actually benefit Black and disabled patients? We talked about intersectionality, so that's important.
Yeah. I mean, this is one of the core issues, right? If you can build technology, but if it's not accessible, not just in the accessibility sense, but accessible to people who need it, it's not going to make broad changes. So one thing that we think about a lot is how do you bring down the costs, right? Such that accessibility is just built into the process from day one. And one of the biggest costs today for digital accessibility is the audit process. Most companies, think of a Target or a Walmart, will hire a vendor, and that vendor will charge them maybe $300 or $400 an hour to audit all of their public sites. Post that audit, you get a paper report that you then take and have to figure out what to do with that paper report. And your engineers hopefully will take that and fix that information. The same is true within healthcare institutions, hospitals, insurance companies, etc. On average, these audits cost $250,000, and the fixes take away from new product development and cost $500,000 to $1 million. So just to figure out if you're accessible and to fix it, and it takes about 6 months, will cost you $1.5 million. Our aim as a business is to bring that cost down to $50,000, which will allow way more institutions, especially institutions that don't have exceptional resources, to be able to do these sorts of activities. So that's one way that we think through this, is how do you bring down costs? And the second is things like this, making it a more informed discussion, such that whenever people are going to their board meetings, whenever people are thinking through where should we put our priorities for the next quarter, 3 quarters, 5 years, they're focusing on accessibility and thinking through accessibility, especially within Black populations. So cutting costs, increasing awareness, these are two of, I think, the biggest levers that we can be taking, especially in making health more accessible for Black communities.
Thank you, and thank you for mentioning intersectionality. So now we're going to go into our round robin questions. We'll open up the conversation where each panelist will address their final question. Donna, how does UCB align its sustainability goals with underserved communities? We talked about the lupus community earlier. And also tell us more about the role of patient advocates, but I think there's a different name for that.
Yes. So how do we align with our communities? We partner and collaborate with our communities. So I say that sort of lightly, but we just mentioned, inclusion in this notion of, to really understand someone's journey, you have to speak to people that have that lived experience. So for instance, we have a project that we're working on, specifically starting with a pilot in Georgia, looking at Black and Hispanic women living with epilepsy. And in that one project, we are partnering with Morehouse School of Medicine. We are proud as much of the methodology we're taking as we are of the outcomes we hope to gain. And part of it is desk research. I know it seems boring, right? But we constantly restart at zero. And that's not only inefficient, but it's expensive. So really understanding, I'm sure even within this room, if we had sat and had all the time in the world to hear all the different work streams that are going on. So looking at what's already happening, we also formed a community, we call it a CAB, a community advisory board, made up of distinct individuals like people with expertise, thought leaders in health equity, thought leaders in epilepsy, thought leadership in advocacy space, things like that. And then thought leaders in policy and access issues, people specifically that work at, for instance, or advise us on Georgia Medicaid. We also have a panel made up of people living with Black and Hispanic women living with epilepsy and their caregivers. And then we cross-reference everything through the data, looking very deeply into understanding, are the qualitative insights fully accurate to determine the root causes? Again, we mentioned prioritize. We have to decide that the interventions we put in place are really addressing that root cause. For instance, in that work stream, we looked at things like geography, race, gender. What we found is, although race, geography, and gender do play a role in causing disparities in that one area, what really was most detrimental is insurance type. So if you were, for instance, in Atlanta, going to try to see a specialist, a neurologist, and you enter a community hospital, your likeliness of actually seeing a neurologist was around 20%. If we turned it around with a different insurance type and went to an academic center or private practice, the likelihood goes up 4 times. So it's just that type of care. And that specific project, you mentioned patient advocate. I knew how to get there. One form of the patient advocate is that community health worker. So after we put that tremendous rigor around understanding the root causes and determining it was potentially that journey of the lower socioeconomic woman living with epilepsy, we are then putting in place a community health worker. Morehouse School of Medicine is hiring a community health worker dedicated to epilepsy, looking to see if we can help. And many of you hopefully know the great work that's already been done in other areas, but it's limited, and the legislation is out there to expand utilization, to get better reimbursement, but it's not where it needs to be. So that project will leverage a community health worker to navigate all the complexities of not only getting to the care they need, the administrative burden, the trust and support, and ultimately to get them on the right treatments that they need and deserve to be well.
That is so important. I'm glad you brought up epilepsy, because a lot of times we don't bring up epilepsy. So thank you for that.
You're very welcome.
Yes.
And by the way, I love your access for all, because if we all believed truly that it was access for all, no one would ever push back on any of this work.
That's right. That's right. Thank you. Also, I want to speak to Herb now. Herb, with no known cure for dementia or Alzheimer's, and this is a really important question, what are some practical solutions for individuals and families? Because this is important, because a lot of times we forget about the support systems. So thank you.
Right. And so we appreciate all the work that our friends in the labs are doing, trying to find a cure. But until then, there are still some things that we can do. So when you receive an Alzheimer's or dementia diagnosis, it's not an immediate death sentence. You can live with it. And there are some practical things you can do. Early detection is key. My mother had Alzheimer's. I turned 50 last summer, so I went to get an early detection analysis. They allowed me to bring the film crew to show exactly what that looks like, because us as males, we're even worse sometimes about getting those things done. But it's critically important, because the therapies and treatments that are becoming available tend to work better once you've been detected early. Participation in research studies, right? And my job as a social scientist is just to present fair information. If you want certain outputs, you have to have certain inputs. So if we want a treatment or therapy to work on whatever my layer of identity is, I need to be included in those research studies. And then lifestyle modifications, simple things. What's good for the heart tends to be good for the brain. So diet, being active, rest, that's really key. Reducing stress within your life, and then being connected to the types of information and resources that's out there. And one thing I found is there's a lot of information out there, but how are we bringing that to bear so that people who need it the most are connected to it? And so we want to do a better job of raising awareness and connecting these information and these resources to the people who needs it. And that's why our film is called Hope and Help. There is hope in the fact that there is help, and you never should have to navigate this space alone.
Thank you. And you talked about accessing information, and that brings us to Michael as he deals with AI and internet. You and I talked about people that hire companies to make sure that their internet, their websites are accessible. So I want to ask you, how can companies ensure that they meet those accessibility requirements, and how can they improve patient experiences?
Yeah, well, there's a set of standards already that exist called the Web Content Accessibility Guidelines, or the WCAG. And if every website just followed those 78 simple rules, I say simple, but they're quite complex sometimes. But if they just follow those rules, then everything would be accessible, or all websites would be accessible. One thing that I often say is, if you don't have a disability today, you'll probably develop one at some point within your life. And I think realizing that, this may be a business, or this may be a tool or a solution that you don't need today, but that someone needs, or that you in 20 years, 50 years might need, helps to make that case a little bit easier. One thing I do want to share is just a couple examples of what accessibility looks like, because I think all of you have probably already used accessibility tools. So if you've ever used a voice input device, you have like Siri type your text message for you, that's an accessibility feature. If you've ever used a keyboard, that's an accessibility feature. If you've used a mouse, that's an accessibility feature. So I often say that innovation happens at the edges of the bell curves, that when you're building for people who are disabled, for people who have different abilities, that's when you find the true innovation that pushes all of society forward. So that's just what we like to think a lot. And when we argue to businesses why they should invest in this, we use those as examples, especially within the health context, to say why you might actually be doing better for your business by becoming more accessible.
So much. Before we wrap, let's do one more quick lightning round in just a sentence or two. What's one action our audience can take away today to make healthcare more accessible and equitable? And also, please tell our audience how they can find out more about your work or any programs or projects that you have coming up.
So in a couple of sentences, collaboration. Collaborate. Me, myself, and UCB have been partnering with BDO the last couple of years, and partnering with groups like that help you understand the lived experience, partnering with your payers. It's not easy, but partnering with them. Some of the biggest successes we've had last year alone, partnership with BDO and MLK III, partnering with Health First, the payer right here in New York, largest payer, getting their support. So not only does it allow for each healthcare stakeholder to contribute, but it allows you to reflect upon the fact that every one of us in the care continuum plays a role in creating inequities and barriers. So until we reflect and realize what we're doing that could change, that's when the real change happens. So my one term would be collaborate. If you want to look into some of the work that we've done, ucb.com. We have our general website. There's a lot on sustainability, on equitable access, things of that nature. And there's also some other publications on there that I've authored, et cetera. So you're so welcome. Thank you.
Thank you for being here today. Michael, what would you like to leave us with today?
Well, I would say hire people with disabilities, listen to people with disabilities, and since you all are serving patients, have deep, deep, deep empathy for the patients that you serve. We're lucky that our name is TestParty, because if you Google TestParty, we're number one. So if you want to find anything out about us, it's just testparty.ai, or just search up TestParty.
And Dr. Caldwell, what would you like to say?
MamaJoeProject.com is where you can find this. I think my colleague said it. It's about partnership. It's about collaboration. Until we get this thing licked, there's not enough tools in the toolbox. So let's continue to move forward with helping the folks who need it most.
So much. So our key takeaways today from today's panel is health equity is intersectional. Race, disability, gender, and socioeconomic factors all play a role. Thank you for all proving that today. AI and technology must be developed equitably to avoid reinforcing biases in healthcare. Community engagement and industry collaboration are essential for driving meaningful change. This has been an incredibly insightful conversation, and I want to thank all our panelists for sharing their expertise and perspectives today during the State of Black Health, What Now? Thank you again to blackdoctor.org and USA Today. And as we make our way up, I'd like to invite the panelists to join CEO Reggie Ware for a photo. Thank you, everyone.